Let's talk a little bit about low back injuries.
Today I'm going to talk about the anatomy of the lumbar spine or low back, and we will kind of go over what can go wrong, what injuries are really common in this area, what you can do to try to mitigate and manage your pain, and give you a little bit of understanding of whether or not you need to be seeking care. Now, of course, every person is super bio-individual, and so nobody's presentation is the same. And that being said, this isn't meant to be like some catch-all for everybody, and certainly low back treatment is never formulaic, or at least it shouldn't be. It should always be individualized to you. So that being said, if you have unrelenting pain or pain that persists for more than 6 weeks, that's definitely a time for you to go see somebody. Even if it's something that comes and goes, that's a recurring thing, right? And so we really ought to get to the bottom of it, because it's not like it just heals and then it's gone. Low back pain in particular is something that a lot of people deal with, and it's also one of those issues that tends to come and go throughout somebody's life. So having a little bit more understanding about how your back works can help you manage it. I also want to start by saying that if you're having any serious radicular symptoms, meaning weakness in your lower extremity, make sure that you seek care. If you have a hard time raising up onto your tiptoes, or if you can't lift your toes up off of the ground, that's an indication that you need to see somebody, because there's probably a little bit something more significant going on that requires some management. And then, of course, if you ever have a change, a sudden change in your bowel or bladder function, so loss of control or inability to empty, or even numbness in the genital region, that's a medical emergency and does require care. However, most of the time, low back pain, even if it's an acute instance where your back goes out and you can't do anything, does not require emergent care. I've been there. I know it feels like it requires urgent care, but it does not. So let's talk a little bit about what goes on, just because it's so common. All right, so we have 5 vertebrae in our lumbar spine, or our lower spine, 5 of them. The T12, or at the very bottom of the thoracic spine, is what articulates with L1. And at that very spot, we start to get a lot more range of motion, because think about it, the rib cage really prohibits a lot of motion through the thoracic spine, in some people more than others. Now, some people, if they kind of get that mid-back pain, it can be because they move excessively from that T12L1 junction, or your thoracolumbar junction. Now, we get a lot more range of motion through our lumbar spine, particularly because this doesn't give it to us in that rotational side bending and extension movement. So people tend to overuse their lumbar spine for those movements, particularly when they're tight here. Now, in a perfect world, we're going to move equally from all of these vertebrae and not overuse one segment in particular. But we're people, and we get tight in certain areas, we get weak in certain areas, and we just develop strange motor patterns the older that we get and the more activities that we do. Particularly if you do something repetitively, you can develop sort of a motor pattern that isn't particularly functional and can wear down one segment more so than the others. Okay, that being said, the L5 vertebrae will then articulate with the sacrum, which is part of your pelvis, right? And so we've got a lot less movement here. So if you're tight through your hips, in theory, you might need to move a little bit more through your lumbar spine. Now, that's also true. That's called regional interdependence. It means that one region is really dependent on what the other regions above and below are doing. So I'll sometimes see somebody for low back pain, and I'm treating their shoulder or their neck, because how they're moving up here is affecting what they're doing with their lumbar spine. Same thing goes down below the chain too, right? So I think that people know, or a lot of people know, that ankle limitations, ankle mobility or stability limitations can transfer all the way up the chain. Myself personally, I know that I have a lot of instability in one of my ankles from repeated strains and sprains from athletics at a younger age. And that has actually kind of caught up with me, and now, because I can't stabilize through that ankle, more force is getting transmitted up through the right side of my lumbar spine, which is where I developed an injury. Now, I also want to take a step back and say that a lot of back pain isn't due to trauma. So if you're somebody that was in a motor vehicle accident, or you had a really, really significant injury, a trauma to the area, this might not be as applicable to you. However, if you're somebody that maybe hurt yourself deadlifting, that one deadlift probably wasn't enough to cause an injury. It was probably the straw that broke the camel's back. You were maybe worn down through one segment more so than the others, so you were more susceptible to injury there. But so many times I'll see people that say, oh, I was making the bed and my back went out, or I threw my back out gardening or picking up my kiddo. So those types of things are typically the injuries that we see with low back pain, and it's really easy for us to then identify that movement as a thing that hurt us, even though that's not really the way it works, right? Because we want to be thinking about moving as best we can through all of these segments. And in this model, you'll see that there's a disc herniation. So I want you to imagine that this person, maybe moves excessively from this region right here. So this is actually I gotta look at it, it's our L3, L4. Very common place to get a little bit of a disc bulge. So we want to think, again, about global movement. So, again, we already talked a little bit about the fact that the lumbar spine will rotate, it will side bend, it will extend, and it will flex. But it's really important to think about the hips also contribute to functional movements where we're flexing at the hip, bending over, right? So when you bend over, you don't want to just bend from here. You want to be bending from your hips. If you are limited in your hips, then you're going to bend at the knee and the ankle so that you can squat. Again, another functional movement that can be really limited in other areas, and then the lumbar spine takes the hit. Okay, so let's talk about specifically what can go wrong. I'm going to talk about discs first because I think that that's something that a lot of people have reached out to me wanting me to talk a little bit more about. So the disc is what sits in between each of the vertebrae. It adds space between the vertebrae and then leaves space for the nerve to exit from the spine and then travel out, okay? So with age, with wear and tear, we can develop what are called degenerative discs. And those discs can just start to lose some of their volume. They can start to wear down a little bit. The outer portion of the disc is a ring of fibers called the annulus. And they're really tough, but they will wear down over time, okay? And in the center of that disc is a material called nucleus. It's kind of like a viscous substance, and that's kind of what allows for that shock absorption. When a disc herniates, there are different levels of that, I should also start to say. So the disc can start to protrude, and in that case, the nucleus just starts to push into the inner fibers of that of the annulus. So that's a bulge. That's when it starts to push. Herniation means that there's actual tears then in those fibers of the annulus, and that disc material can start to come out. Now, in an extrusion, the disc material actually starts to leave the confines of the annulus and protrude past that. And then finally, we can have sequestration, where that material completely comes out. It is now no longer dislocated, or no longer connected to the disc itself. So we diagnose that with imaging, right? So MRI. But here's the deal. If you have an MRI of your back and you're not having any pain, chances are you're going to show some disc changes if you're above the age of 30 and you're an athletic person. So I always remind people that images are helpful in putting together the big clinical picture, but the most important thing is what you're experiencing. So I don't want people to get really hung up on, I have a disc bulge and now I can't do X, Y, and Z. Because we do know that discs heal. Some will just spontaneously reabsorb that nucleus. Some stay herniated, and an MRI looks totally nasty for the rest of their life, and they have no pain at all. So let's just keep that in mind with all of this. Because disc herniations just sound so scary, at least they did to me. And in fact, there's a lot of literature that shows that once people actually see their MRI, particularly if there's damage, their pain gets worse. So a little bit of the power of suggestion with that, right? All right, so let's get back into what it means when a disc herniates. If you can imagine, when you bend forward, there's a fair amount of load on the front of this disc, and this is a jelly-like material, so it will push backwards. So typically people with disc issues tend to have pain with flexion-type movements, so bending forward, going to put your shoes on. Even sitting for prolonged periods, we tend to get a little bit more of a flexion moment, and there's compression when we sit. I talked about this in a couple days ago in a post, that there's so much more loading of your spine when we're sitting. You'll also maybe notice, if you have significant disc pain, that you have increased pain with like a cough or a sneeze, or anytime you bear down. That's a sign that maybe you're not loading your abdominal muscles correctly and you're not breathing correctly. So again, I talk a lot about, in my posts, being able to expand your abdomen in 360 degrees. And when I say 360 degrees, I know this is 180 degrees. So I mean being able to get your abdominal canister, your pelvic floor at the bottom, your diaphragm at the top, and your abs wrapping around to move in 360 degrees, so that when you inhale, that entire volume will increase and the pressure goes down. Then when you go to brace or lift and you contract, you're able to do that in a controlled way so that the pressure increases and stabilizes your spine without causing pain. Now, if you're really acutely flared up, anything that increases that intra-abdominal pressure is going to be painful, which is why when you cough or sneeze or you yell, that diaphragm dropping down creates pressure in your abdominal cavity that translates back and puts pressure on that disc and causes pain. Okay, so that's disc stuff. If you are somebody that you suspect you've got disc symptoms, you're probably somebody that notices that your pain might be worse in the morning. You might feel like, oh my gosh, I have a really hard time standing straight up after I've been asleep all night. Or if you've been sitting for a while, maybe you don't have pain when you're sitting, but then you go to stand up and you're like, oh my gosh, that's terrible. If a disc bulge is significant enough, you could get compression on one of these nerve roots, and then you can have radicular stuff down your leg. It depends on which level is affected as to where you notice that pain. Now, radicular pain is really, really uncomfortable. Again, I'm speaking from experience. I have terrible radicular pain. However, it's not necessarily a medical emergency, even though it feels like it could be. If you're dealing with that type of pain, the best thing you can do is focus on more extension-based movement. Now, there's a caveat to that. If you have a really, really major amount of pain with backward bending, we don't want to push into that. So, again, thinking about what is painful for you. And in the cases of disc herniation, typically you've got a really good idea of what hurts you. So you know what? What you want to do is avoid those things. Allow that disc material to reabsorb. So if you have a one-sided injury, like let's think, for example, that you have pain on the right side. If we're continually trying to side bend, you could get some compression of that nerve root if the disc bulge is huge. Now, if you notice that side bending the other way gives you a little bit of relief, great. That could actually be a really good thing for some people, depending on the amount of bulge that you have. What we have to be mindful of is that we don't want to then push that disc material too far out. So if you imagine that I have a little bit of a bulge on the right side and I side bend to the left, I could squish that jelly more to the right. So again, thinking about what causes pain. This is how a good PT should think. It's not really dogmatic in that, okay, if this, then this. It's if something hurts the person, we want to keep you out of that position. So bottom line, disc issues, avoid sitting for more than 20 minutes at a time best you can, and focus more on extension-based activities. So lying on your tummy and maybe doing some prone press-ups. Really being mindful of maintaining that neutral spine, practicing a hip hinge. Squatting might be okay, but maybe we're not going down into full range. Forward folding, probably not so great. It might feel really good in the moment, but if it flares you up afterwards, there's a chance that you have a disc injury, okay? And if you're having a hard time distinguishing what's going on, obviously go see somebody. Now, we can also develop more extension-based issues, which can come, from repetitive trauma. So you could certainly develop a little bit of a stress fracture in your spine that can give you some instability, that makes one vertebrae slip forward on another. That can happen insidiously, it can happen over time, or it can be genetic in nature. So this is something that I really, really encourage people. If you've got unrelenting comes and goes, back bending feels really bad, it feels really unstable, go see somebody for that. Because a good clinician should be able to rule that out. But the great news for that is that just typically requires stability, assuming that it's not a really, really major issue. So that's called a spondylolisthesis, when a vertebrae can start to slip forward. That fracture can happen on one side or both, and it gives you that instability. Similarly, with repeated extension loading, so if you tend to really extend through your spine a lot, you can create a little bit of inflammation in your facet joints. So facet joint arthropathy or arthritis can be something that can be really uncomfortable. And along similar lines, if we have loss of disc space and you tend to extend more, you can get compression of those nerve roots simply because the space decreases, and we call that stenosis. typically we see that these people have more pain when they're in gravity-dependent positions, so standing more so than anything. Sometimes they have it with walking around. These are the people that we want to avoid doing extension-based stuff and really start to promote more flexion. So you should have a really good idea of like, okay, it feels bad to arch. It feels better to lean forward. That's the most simple test to kind of determine, do you have a tolerance for flexion or do you have a tolerance for extension? So if you've got an extension-based movement impairment, again, we want to really be thinking about strengthening the core, changing the way that you move so that you're not getting repetitive extension in this area. Now, of course, you can have a combination of both. I see a lot of people that have facet joint issues or a spondylolisthesis and a disc. So if it gets complicated and you're really muddying the waters in terms of not understanding what you should be doing, talk to somebody. I know that's what I keep saying. And then, of course, we can get acute muscle strains. Acute muscle strains can happen when you pull a muscle in your back. Again, those are going to respond better to rest. The other conditions tend to be, a little bit more responsive to movement. I think that in the first couple days after a back injury, it's hard to discern what caused it or what led to this flare-up, as a lot of us call it. Let yourself rest a little bit in those instances. And then start to increase your activity, because typically movement helps things. And find movement that makes you feel better. Maybe that's walking for 10 to 20 minute bouts and slowly starting to see how you feel. Be really mindful when you move. Be mindful of being able to keep your spine in neutral, and just keep in mind what movements tend to flare you up and avoid those movements. And it sounds like that is really simple, and it is. I think that we sometimes really overcomplicate back pain. Again, I know that I've done that. So start to pay attention to what movements feel bad. If you're having a lot of shooting pain down your leg, one side or the other, and you're not having any weakness or even numbness tingling in your legs, so pain or numbness tingling down your legs, start to notice, do those symptoms get worse with forward flexion? Do they get worse with backward extension? Or how is side bending and rolling? In the acute period when you're flared up, rest a little bit. Try to keep your spine neutral. So when you're sitting up in bed, you want to roll to your side first, just so that we're not creating any undue stress on any of these structures back here. But within a couple of days, do your very best to get back to some movement. And if things don't respond in a short amount of time, go see somebody. But again, the big take-home message that I want you to have is that it varies for everybody, but more often than not, these type of injuries respond really well to conservative care. So try not to freak out about it. I know it's so hard, particularly when you're experiencing really intense low back pain. But know that the body is really incredible. These tissues tend to heal really well. And if you can learn to move in a way that is a little bit more appropriate for your anatomy, you will mitigate your chances of having future flare-ups.